Hello friends, let us now learn some important points about the pharmacogenetics and pharmacogenomics. So first, in the pharmacogenetics, we will learn some important points about pharmacogenetics. Pharmacogenetics is effect of genes on the drugs. What is pharmacogenetics? That is the effect of genes on drugs. If you see an example, if there is a gene and that gene is more powerful or it can be less powerful. If the gene is more powerful, then that means it has more receptors and more enzymes, and thus it can cause drug failure. Then if the gene is less powerful, then that means it has less receptors and it has less enzymes. That means the drug, because it has less receptors and less enzymes, the drug is not metabolized properly, so it causes drug toxicity. So if you see the pharmacogenomics is based on the individual pharmacogenetic composition. That means we have to individualize the drug therapy based on the pharmacogenetics of the individual. So in order to avoid the drug failure, we will have to increase the dose of the drug, and in order to avoid the drug toxicity, we will have to decrease the dose of the drug. So all this comes under pharmacogenomics and pharmacogenetics. So in this class we are going to learn many examples which will tell us the differences between these. So first and foremost is we have two types of polymorphisms are present. One, target polymorphism, second, enzyme polymorphism. First we will learn about target polymorphism, which is VKORC1 gene polymorphism. That means vitamin K oxide reductase gene polymorphism. So we have vitamin K gets converted to active form of vitamin K, this active form of vitamin K will activate the gamma carboxylase enzyme, which will also activate factor 2, factor 8, factor 9 and factor 10 coagulation factors along with protein C and protein S. So this warfarin will inhibit this vitamin K oxide reductase. Then if there is vitamin K oxide reductase, that is VKORC1 gene, if this gene is more powerful, then this will cause more conversion of vitamin K to active vitamin K and more carboxylation and more activation of coagulation factors. So if it is less powerful, obviously there is less activation of coagulating factors. So warfarin has variable effects in a person based on the presence of the VKORC1 gene. So if the person has more powerful VKORC1 gene, he has more activation of clotting factors. If he has less powerful VKORC1 gene, then he has less activation of clotting factors. So this mainly depends upon this gene. So warfarin has variable effects, so we will have to monitor the PT and INR values of that person. Then if you see the second drug, second is we have ryanodine receptor polymorphism. In ryanodine receptor gene polymorphism, normally we have ryanodine receptor gene. The drug, this ryanodine receptor gene will activate ryanodine receptors on the sarcoplasmic reticulum and thus activate calcium efflux. Okay. This calcium efflux causes reuptake by calcium ATPase, right? So if ryanodine gene will cause calcium efflux, right? So if there is the drugs like halothane, lidocaine, succinylcholine will activate these ryanodine receptors. So if the ryanodine gene is more powerful, then it causes more and more uptake of calcium by calcium ATPase. So calcium ATPase increases uptake, so there is increased utilization of ATP, and which causes heat production, and this property is used in malignant hyperthermia. Then we have the next drug, which is ACE polymorphism. ACE polymorphism will decrease the effect on ACE inhibitors. So Then we have fourth polymorphism, which is beta 2 receptor polymorphism. This will decrease the effect of beta 2 agonists. Then we have HMG-CoA reductase polymorphism. This HMG-CoA reductase polymorphism will decrease the effect of statins on our drugs, right? Then we have to learn about the enzyme polymorphism. In the enzyme polymorphism, first we have CYP2C9 polymorphism. This CYP2C9 polymorphism is mainly used for metabolizing the warfarin. It will metabolize the warfarin. Then we have one more polymorphism, which is CYP2C19 polymorphism. This CYP2C19 polymorphism, this is a cytochrome P450 enzyme type. It will activate clopidogrel. So if the gene is less powerful, this decreases the CYP2C19 enzyme. So obviously it causes decreased activation of clopidogrel, and thus it increases the risk of MI. So FDA has issued black box warning for this drug clopidogrel for these patients. So we would not use this clopidogrel without knowing the polymorphism status of the patient. Then we have the third polymorphism, which is CYP2D6 polymorphism. So we have CYP2D6 polymorphism. This will decrease the metabolism of tricyclic antidepressants, SSRIs and antipsychotics, and thus causes toxicity of the drugs. Then this polymorphism will also decrease the activation of tamoxifen, and thus it will decrease the endoxifen effect, and finally which decreases the inhibition of estrogen receptor, thus causing failure of drug. So this is about the CYP2D6 polymorphism. According to Mayo Clinic guidelines, there is mandatory CYP2D6 genotyping should be done before we prescribe the drug. So this is about CYP2D6 polymorphism. Then we have the fourth drug, which is butyrylcholinesterase polymorphism. In butyrylcholinesterase polymorphism, we will this butyrylcholinesterase will metabolize the succinylcholine. This butyrylcholinesterase gene which you are talking about here is less powerful. So as a result, there is increased succinylcholine because of decreased metabolism of succinylcholine, which increases the succinylcholine in the blood, causing prolonged apnea. So this is important. Then the fifth is we have G6PD gene polymorphism. In this G6PD gene polymorphism, this will make the gene less powerful and thus decrease the G6PD, thus causing hemolysis. Examples of this G6PD polymorphism include, we have the drugs like menadione, and we have antimalarials like primaquine more than chloroquine, and then we also have drugs like nalidixic acid, nitrofurantoin, and the other drugs like isoniazid, sulfonamides and dapsone are also present, and also hydralazine. All these have G6PD polymorphism. So if you give these drugs in G6PD deficient individuals, or then this will cause hemolysis will occur, leading to G6PD deficiency anemia. Now the sixth enzyme polymorphism is N-acetyl transferase enzyme polymorphism. This is N-acetyl transferase 1 gene which can be more powerful, or N-acetyl transferase 1 gene which can be less powerful. N-acetyl transferase 1 gene, if it is more powerful, it causes fast acetylers. If it is less powerful, then it causes slow acetylers. For example, in isoniazid, if it is given in powerful gene, then there is increased metabolism of isoniazid, forming increased metabolites which causes hepatotoxicity. If it has slow acetylers, then isoniazid will decrease the metabolism and thus it will increase the isoniazid, causing increased peripheral neuropathy. So that is the side effect of peripheral neuropathy is seen in slow acetylers, and the side effect of hepatotoxicity is seen in fast acetylers. So this is about the gene polymorphism. Thank you for watching.